morning, everyone, and welcome to the Heart to Heart discussing our future of cardiovascular genetics care in BC. I'm Erin DeBruin, the project manager for genomic education for healthcare professionals at Genome BC, based in Vancouver on the traditional, ancestral, and unceded territories of the Coast Salish people, the Musqueam, Squamish, and Tsleil-Waututh nations. We are gathered here virtually, and so I would like to also acknowledge the Indigenous peoples who have cared for these lands for thousands of years, including in the many communities that all of you call home. Over the past 2 decades, precision health has significantly improved patient outcomes, most often in the research setting. But here in British Columbia, we're witnessing a growing momentum in integrating precision health to the standard of care. The evolving and expanding use of genetic testing and information is changing how we deliver care in areas such as cancer, pharmacology, and transplantation. Today, our panel will highlight some examples of how genetics is changing the way we manage cardiovascular health. Yet there are still hurdles to overcome before precision health can become a widespread reality in BC. One such challenge, important to today's discussion, lies in capacity building, a cornerstone of the widespread adoption of genomics in healthcare. This means ensuring that we have the necessary expertise and resources to effectively utilize genetic information and improve patient care. We need more genetic counselors to share their expertise, support alongside physicians, nurses who understand the value of genomics and access the necessary tools. All of these components are essential to making precision medicine accessible and applicable as part of the standard of care patients need to thrive. Today, we're privileged to have Kirsten Bartels, Provincial Project Lead for Cardiovascular Genetics at Cardiac Services BC, here to set the stage for our heart-to-heart discussion. Kirsten will introduce the evidence-based genetic testing for cardiovascular conditions currently being used in BC and shed light on future plans for improving access to cardiac genetic services. Following Kirsten's insights, we'll be joined by esteemed experts Dr. Liam Brenham, Lindsay Burnell, and Dr. Thomas Rolston, who will share their experience in cardiovascular genomics. This webinar isn't just a one-way conversation. We want your input and questions, so please feel free to engage with us using the Q&A function at the bottom of your screen. Your participation is integral to the success of today's discussion. And with that, let's dive into the world of cardiovascular genetics. Welcome, Kirsten. Over to you to get us started.
Thanks so much, Erin. I hope everyone can see that okay. So thanks, Erin, and thanks to everyone at Genome BC for inviting myself and the other panelists to discuss this important topic today. I'm really looking forward to the interactive Q&A a bit later. So as Erin said, I'm the Provincial Project Lead for Cardiovascular Genetics. I'm the Provincial Project Lead for Cardiovascular Genetics at CSBC, but my background is as a clinical genetic counselor. At today's Heart to Heart, we will be touching on aspects of the utility of evidence-based genetic testing in cardiology specifically. And these are sort of the 3 key areas that we had highlighted for the session today. And hopefully through our panelist discussion, these can exemplify much of the landscape of the utility of testing in the current state in this space. And then I'll hopefully do a decent job of setting the scene for the value of adopting genetics with the family at the center of care and what the future of cardiogenetics care might look like in BC. And part of that is planning for implementation of a new Provincial Cardiovascular Genetics program. So cardiovascular genetics is a rapidly evolving subspecialty within cardiovascular medicine, and its growth is attributed to advances in genome sequencing and genetic testing and the expanding understanding of the genetic basis of cardiovascular disease. And this includes areas like arrhythmias, heart failure or cardiomyopathies, lipid disorders leading to coronary artery disease and aortic disease. I just wanted to start, I didn't know where to start, but I wanted to start with this graphic perhaps to give a nod to the quote, state-of-the-art genetic technologies that are revolutionizing cardiovascular precision medicine. There's much happening in the field of cardiovascular genetics, and most of which we won't be touching on today. But all this to say that it's an exciting time in this area of medicine and research. Importantly, some inherited or genetic cardiovascular conditions can carry an inherent predisposition or increased risk for sudden cardiac death. However, if the risk is recognized and managed early, sudden death can be prevented. And so genetic information plays an important role in preventing these outcomes. The mainstay genetic test has been clinical genetic or genomic sequencing, so the blue circle there, looking for causes of monogenic disease. However, generating a genetic risk score there in purple for polygenic disease is emerging in many areas. So there's many different ways in which we can obtain and use genetic information to improve outcomes for those with inherited cardiovascular disease. So the diagnostic power of genetic testing is significant across the spectrum of cardiovascular disease. In the clinic, the integration of clinical cardiovascular findings with genetic information via genetic testing can do a number of things. It can help clarify the diagnosis and prognosis of diseases that cause similar clinical presentation. It can help physicians choose appropriate treatments and plan appropriate timing of those treatments. And it can help identify relatives at risk for cardiovascular disease before disease symptoms start. If a disease-associated gene variant is found in a proband or the first person diagnosed in the family, then it can be screened for in their relatives, and that's called cascade screening. And what's starting to be added to this and will eventually be officially added, I guess, to my graphic, is to identify patients for targeted therapy. So this is things like gene editing, silencing technologies that are currently under development for several genetic diseases. So this evolving and expanding utility of genetic testing and genetic information is pushing us to change the way we deliver care to fulfill the promises of precision health and ensure all that those who need genetic testing and genetic counseling can access it. And there's challenges that we still face with genetic testing today. One of these is the interpretation of some genetic test results is still complex, and the evaluation, counseling, and management of genetically at-risk family members who have inherited that gene variant but do not yet manifest disease. So with these advances and challenges, there's a need for integration of both cardiovascular medicine and genetics expertise. I mentioned that we're being pushed to change the way we provide care to realize the promises of precision health. And one way is moving the care paradigm in cardiovascular medicine beyond the patient to the at-risk relatives. So collaboration with and care for the family unit is an essential component of genetic evaluation. Evaluation of both the original patient and their close family members provides the essential pieces for completing the puzzle of diagnosis, how the disease may manifest in the family, and the interpretation of their genetic test results. Furthermore, this family-based model includes developing integrated teams with pediatric and adult training and expertise that are able to provide coordinated care across the age groups and bridge the gap between adult and pediatric care. So I'll speak now to what's going on in the BC context. And, cardiovascular genetics is a broad umbrella, a large field of medicine and research. This is just one way to break it down into these sort of broad disease groups. And so I won't be touching on all of these today, and I'll be speaking specifically about the work that I have been involved with and that Cardiac Services has been leading over the past number of years in cardiovascular genetics. So in 2012, the Specialist Services Committee, in partnership with Cardiac Services, supported the development of the BC Inherited Arrhythmia program. So this was designed as a pilot project, and the BCIP was narrowed in scope to focus solely on inherited arrhythmias. The BCIP was launched in 2013 with a clinical team that was comprised of cardiology, medical genetics, genetic counseling, and pediatric specialists, so that integration of cardiovascular and genetics together. In parallel, other cardiovascular genetics clinics have evolved across BC to meet the broader needs of this population. And these services have been building much needed capacity, expertise, and connections in their regions and across BC. However, due to the many competing priorities for resources throughout the system, there is minimal coordination and strategic alignment among these emerging clinics, resulting in services that are not sustainable and not optimized for family-based care. Approximately 80,000 individuals in BC are at risk for inherited cardiovascular conditions that fall under these 4 disease groups. So inherited arrhythmias, cardiomyopathies, lipid disorders, and aortopathies. And it's estimated that these efforts have reached only 15% or less of patients and families affected by these conditions. So CSBC is leading a provincial strategy and health human resource plan to better integrate care and provide a service that's efficient, consistent, and equitable, regardless of where the patient and their family members live in the province. CSBC engaged diverse stakeholders from across BC and brought them together to inform, consult, and collaborate on the development and implementation of a centrally coordinated, family-based provincial cardiovascular genetics program. There's collective momentum and consensus among these stakeholders to move towards a more holistic approach with a common goal of closing the care gaps and preventing any further unnecessary sudden cardiac death in BC. The proposed provincial service is a highly specialized collaborative network of interdisciplinary care providers focusing on referral and case management of families with these conditions. The service will include a central intake and coordination of referrals and case management with a provincial genetic counseling team supported by virtual technologies. Other clinical services within this program will be coordinated with existing care providers and delivered centrally or regionally, depending on case complexity, the family's needs, and the local resources available. And it will provide a shared care model that will enhance skill sets and knowledge of primary care and regional specialist providers. So through this work, important new partnerships have been formed, including with the Provincial Laboratory Medicine Services and Medical Genetics to support alignment with the emerging provincial genomic strategy, as well as the BC Coroner Service to enhance sudden cardiac death investigation, including postmortem genetic testing and support and assessment of the grieving family. And of course, I must mention our valued connection with Genome BC and our opportunity to contribute to their Genomics Education for Health Professionals program. And so I hope this is setting the stage for a great discussion today. And with that, I would like to pass it back to Erin.
Thank you, Kirsten, for a great summary of where we are now and provide a glimpse into the capacity that we need to build to realize the proposed cardiac genomics future for BC patients. As you mentioned, Genome BC has been helping to build capacity through its Genomic Education for Healthcare Professional program. We are proud to have worked with the ecosystem to develop the genetic services pathway. And I'll just bring that up now for everybody to see. So this list allows us to understand the genetic services that are available to BC residents in one central location and help non-genetic specialists, such as cardiologists and primary care providers, navigate the individual clinics and testing options to support the genetic assessment. So this list is called the Genetic Assessment and Testing Care Pathway, and it is available on Pathways BC. Pathways BC is a curated guide to health-related information on the web, and the primary focus is on the clinician portal, where healthcare providers can provide up-to-date information on clinic referrals and other health initiatives. This is also where this genetics care pathway can be found. For the public, there are 2 directories supported by Pathways. The first is the Medical Care Directory, which provides information about primary and maternity care services in BC. And the second is the Community Services Directory, which includes information about the health-related program supports available in the community. The Genetic Assessment and Testing Care Pathway is just one way that Genome BC is helping to increase knowledge and improve patient care. It is now my pleasure to introduce the rest of the panel. Dr. Liam Brenham is an associate professor in the Department of Medicine at the University of British Columbia and a Canadian research chair in precision cardiovascular disease prevention. He is also the medical lead at the Heart Program Prevention Clinic at St. Paul's Hospital, one of the largest specialty lipid clinics in Canada. Lindsay Burnell is a clinical genetic counselor who has been working with Island Health since 2016. She currently focuses on cardiogenetics, seeing patients with cardiomyopathies and inherited arrhythmias. Dr. Thomas Rolston is a cardiologist and clinician scientist at St. Paul's and Vancouver General Hospital. Dr. Rolston's research focuses on cardiac genetics, heart disease in the young, and critical care cardiology. Without further ado, Thomas, can you start us off? As a specialist in cardiogenomics, can you walk us through how a patient might be referred to you after a member of their family might have received a genetic diagnosis? And what information is essential for you to have in this referral?
Thanks, Erin, for the question, and thanks everybody for joining. It's a privilege to talk about this topic today, which is very important. So I think that's a very practical question, but unfortunately it doesn't have a completely clear answer, because when we talk about cardiovascular genetic disorders, there's a wide range of conditions that we commonly see. So all the way from lipid disorders, which really for the most part only require a single blood test to make a diagnosis, all the way to structural heart conditions, aortic conditions that require often advanced imaging, which is not easily ordered, for example, sometimes by a primary care provider. So it's a bit difficult to answer that question, but what I would say as an overall theme is what we really want to emphasize is that if the referral is placed to us, we will do always our very best to assure that the appropriate clinical testing is either done before or at the time that they see us. So the most important thing is that the referral takes place. So we like to see people who have a family member that carries a potential genetic diagnosis, either confirmed or unconfirmed. And then for the structural heart disease problem, we order an ECG and an echocardiogram. So that's an ultrasound of the heart and a rhythm strip as a basic test. If the patient's family member has an aortic disease, we usually at a baseline get an echocardiogram to look at the aorta, which is the main blood vessel leaving the heart. And then if somebody has a familial arrhythmic disorder, we usually will order things like exercise stress tests and Holter monitors, which are prolonged rhythm monitors or monitors during exercise. And then lastly, if you have a cholesterol disorder in your family or someone with early onset heart artery disease, we really like a basic cholesterol profile, but also very important to consider whether or not ordering some of the extra tests that are available, like a lipoprotein little a or an ApoB, might help make the diagnosis. So I know that's a bit of a long answer because it is a complex evaluation of these individuals. But I think the key emphasis is if there's a potential genetic condition in the family, we really just want the referral placed, and then we can often sort out the rest of the details.
Thanks very much, Thomas. Lindsay, family histories are a common tool to identify inherited diseases. Can you tell us about how you approach collecting family histories as a genetic counselor and highlight where this approach can help identify other family members that might need to be tested through cascade screening?
Thanks, Erin. Yeah, so family history is obviously a big part of what we do as genetic counselors. And I think, I would think about two main things that we want to accomplish when we're taking a family history. The first is really just obtaining the information about the family structure. So the patient in front of us, how many children do they have? How many siblings? Aunts and uncles, we're going back at least another generation and just determining how many family members are there, and basic information, who is still living, who has passed away, that kind of thing. And then we're really focusing our health history as part of the family history. We're focusing questions on why that patient has been referred. So we're asking questions about, is there anyone else in the family with a similar condition? How old were these people when they were diagnosed? Much more specific questions depending on the condition. So does anybody in the family have a device like a pacemaker, a defibrillator, for example? Sometimes even, questions that don't seem to technically fit. So if we're seeing a patient for cardiomyopathy, is there also a family history of other muscle disease within, with other relatives? So those kinds of questions. And so when we're looking at asking those specific questions, we're looking for clues within the family. Do we see kind of a cluster of presentations that is pointing us in a certain direction? Do we see a pattern of how something might be being passed along in a family? And that can once in a while direct kind of what testing we might be offering, or give us an idea of what we might find. It's also important, going back to obtaining the family structures, if we then do genetic testing and we find something, we then know who else in the family are we going to be offering that genetic testing to, who else is at risk. And then even if we don't find something, who in the family should be having screening done. So who should be checked? Even if we didn't identify something with genetic testing, there might be individuals who still need to be screened with things like an echocardiogram. So the family history is, there's really those two important points when we're taking the family history. But I also want to point out that kind of a misconception is often when we're receiving referrals and we'll contact a patient, they'll say, I don't have any family history information. I don't have contact with my family, or I was adopted, and so I just don't have that biological info. And I just like to say that that's okay. We're still willing to see people in those circumstances. And of course, some families don't communicate health information. So even if you don't feel like you have a lot of information, that referral is still important, and we will take any information that we can get.
Liam, an important theme we hear in healthcare reform is that we need to prioritize prevention initiatives over always waiting to provide care after people are sick. How does implementing genetic testing and cardiovascular care help us to do that?
Thanks for the question, Erin, and also for the opportunity to be here for this panel. And amazing to see 90 attendees joining us today. So thanks so much for everyone who's taken the time to be here. It's a really important question, and I'll try to answer it by giving a couple of examples. So when it comes to how we currently try to predict an individual's risk for heart disease, we use risk scores or risk algorithms that help us make decisions about when we should start using medications or other strategies to lower someone's risk. And those risk scores are based mostly on age, also on things like presence of diabetes, cholesterol levels, blood pressure. And these are all things that tend not to occur later in life. Of course, age, of course, directly related to how old someone is. And so they're very much reactive in terms of waiting until somebody has developed these risk factors, and then we decide, okay, it's time to start doing something to lower their risk. Or we might wait until we see, for instance, on a CT scan, that there's already evidence of cholesterol buildup in someone's blood vessels. We contrast to a genetic test. The great value of a genetic test is that the genome is fixed from the time of conception. So even prior to when we're born, our genes and our genetic variants are already there. And so in theory, we could be doing genetic testing very early in life, and it would be a one-time test, and that would inform on risk much, much earlier, before we would see some of those other risk factors, allowing us to intervene at a much earlier time point and hopefully put someone on a different trajectory in terms of delaying or entirely preventing them from developing heart disease. Another area where this is very important is in something called cascade screening, which Kirsten alluded to. And so, as you know, Erin, we're conducting a study that Genome BC is supporting, looking at patients that come into hospital with a heart attack at a young age. And we're offering them a genetic test to look for the presence of a certain type of inherited cholesterol disorder. And in some of these people, about 10%, we find they actually have a genetic condition causing high cholesterol that was likely a contributor to why they had that heart attack in the first place. And that's important information for that patient. But even more important is for that patient's family members. So their children, their siblings, even their parents who do not yet have heart disease. And we can then take that genetic finding and test those related family members. And that's what we call cascade testing, and hopefully make that diagnosis before somebody ends up in an emergency department with a heart attack, so we can take steps to actually prevent them from becoming sick in the first place. So those are a couple of ways in which genetics can be used to help make earlier diagnoses and hopefully institute steps to prevent disease.
Thanks, Liam. I'm going to do a quick interjection with one of the questions from the audience, because I think it fits here very well. So it says, in an early diagnosis of cardiovascular disease, is it more likely to be associated with a genetic mutation? Do family histories have relatives who experience MIs, strokes, etc. at an elderly age less likely to have a disorder in the family, as cardiovascular events are typically common among this aging population?
We have to be a little bit careful here in terms of some of the terminology. So when cardiovascular disease happens at a young age, and when I say cardiovascular disease, I'm speaking specifically of atherosclerotic cardiovascular disease, heart attack, stroke, things like that. When that happens at a young age, it's much more likely to be heritable, meaning there's a genetic component to it. And we know this from a beautiful series of twin studies, which showed that among twins, if one twin has a heart attack at a young age, so under the age of about 50, the other twin is at very, very high risk of also having a heart attack. Whereas if one twin has a heart attack at age 70, the risk in the unaffected twin is really no different from the rest of the population. So that's really what's taught us that the genetic contribution to heart disease is much higher when it occurs at a young age. But that's different than saying there's a genetic mutation. Heart disease is a genetically complex disease. In the vast majority of cases, it's not caused by a single genetic mutation. It's caused by a number of different genetic variants which interact with environmental and other factors to ultimately lead to the disease. But yes, with a genetic, and so that has implications because there's not necessarily a genetic test in the term of clinical sequencing, like what Kirsten referred to, that's appropriate in that case. But the genetic contribution to disease is definitely much greater when it occurs at a young age.
Thanks, Liam. Kirsten, you talked about needing to build a shared care model to support the new Provincial Cardiovascular Genetics Program. What are essential parts that we already have and what still need to be developed?
Thanks, Erin. And I'm tracking the questions in the chat, and I think I might try to answer some of them through my answer to this question, because there's been a couple of questions that have come in just asking about the referral pathway, if for patients and families who are wondering about diagnoses in their family. So I think what we have, where we are now and where we want to be. So what we have now is we have, as I said in the intro, we have good experts, world-renowned experts residing in the province who to some extent have come together to start to provide care to patients and families in this interdisciplinary model. And through setting up these new services, have done a good job of connecting with other providers in various regions around the province to build expertise with those who might be sharing care with for their patients after that sort of initial assessment. So we have the beginnings of coordinated care occurring in lots of different areas. I think the thing to keep in mind is, and we have a very motivated group of people who want to see improvement in care. What we don't currently have is provincial standardization and coordination of these services and how these patients might flow through the system and how they might access the system. So patients who have inherited cardiac conditions can access cardiac and genetic services in various ways, shapes, and forms, but it is currently fragmented. So what I would say is that in the current state, and to answer some of the questions that have come through the chat, if you're wondering about a referral into one of the existing services, one of the great resources that you could tap into is the new genetic referral pathway that BC has developed in conjunction with Pathways BC. So if you were to go into Pathways, you would be able to access like the acceptance or referral criteria for each of the existing programs in various different both provincial services and regional services. In terms of how you might access a cardiovascular genetics program to become in the future, that's really what we're trying to achieve, and that's one of the things we don't have is a more simplified way in which folks can access these services. And one of the intentions of centralizing the triage, at least initially, is to take a very fragmented and confusing system and simplify it so that patients and families and their care providers can access these services in a coordinated way. So I would say this is one of the goals of the Cardiovascular Genetics Program project through CSBC. And although we've, again, made some headway in building these partnerships and creating these networks and working with Genome BC on getting information out there that will help folks navigate the current state system, because this is a field that has been expanding fairly rapidly over the past 10 years, we do also require some human health resources to put behind this. Erin, you had mentioned at the very start that we need more genetic counselors, which is a biased take from my part, being a genetic counselor, but we certainly do. And so we're hoping that through this project that we were able to put some new human health resource behind this, and again, enable access and make things simplify when it comes to the time of referral and getting those patients and families seen. I think I'll leave it there.
Thanks, Kristen. And just to clarify, the genetic services care pathway is available only to clinicians. So if patients are interested, they need to have a conversation with their primary care provider, or if they're already seeing a cardiologist, to talk with them about how they would then be referred further on for these opportunities. Lindsay, with an increasing number of guidelines being that recommend genetic testing to support cardiovascular conditions, how as a genetic counselor will your practice need to change to be able to support this additional volume?
Thanks, Erin, and maybe I will touch on some of the things that are already available as part of my answer to this question. So apart from needing more human resource, so more genetic counselors potentially or other healthcare providers like Kirsten mentioned, I think we're really going to have to start moving away from that traditional genetic counseling model of a one-on-one hour-long appointment that some of us were trained to expect or trained to carry out, and really look at different ways that we can connect with patients, both to increase our volume, but also to make access easier, as well as find ways maybe to integrate those discussions about genetic testing into other aspects of patient care. So in Island Health in the last couple of years, we've made a few of these changes because we were seeing such a high volume of patients start to come in, but also because we've been making connections with some other specialists, so cardiologists, for example. So the two main things that we've done is the first is we've started offering group genetic counseling appointments. And so these are done virtually over a Zoom platform, really just like this. So they're webinar format, so privacy is maintained. But at this point, we're able to offer up to 8 patients at a time an appointment to discuss the options of genetic testing or to go through all of the information with them. And so that, of course, is opening up more patient slots. So it's saving us time as genetic counselors, but also people are very receptive to this option. And maybe in part because of the pandemic, we've had that shift to virtual care. But they're also, they're able to sit at home and learn this information. And so we've definitely seen a reduction in our wait time because of this option, which is great. The other thing that has changed in the last couple of years is rather than having genetic counselors who are doing cardiogenetics located only at the medical genetics clinic, we're really branching out. So I now spend 3 days a week right down the hall from the heart function clinic, which is where a lot of patients with cardiomyopathy are seen. And we were getting a lot of referrals from the heart function clinic. So instead of the cardiologist in that clinic making a referral to medical genetics, us triaging that referral, patients then sitting on the wait list for months or even a year, we are really streamlining that. So I'm able to see the patient at the time of their cardiology appointment. And so we're saving kind of time because we're taking out those middle steps. But I'm also finding that my discussion with patients tends to be a little bit shorter. And I don't think that they're missing any of the genetic information, but they have just met with their cardiologist. They have a reference as to why we're offering, this testing. I don't need to go through some of their health history because that's already been done. And so it's really more that team approach, and it's saving us time. We're getting patients in faster. And so we're really seeing the benefit there. And the same thing is happening with a monthly clinic with a cardiologist who sees hypertrophic cardiomyopathy. So again, seeing patients at the same time that they're seeing a cardiologist. And these ideas of group counseling and integrating genetic counselors within other clinics, they're not new. I mean, the BCIP is one example that's been doing it for some time, but group counseling has been done within the province through the hereditary cancer program for a long time. And the hereditary cancer program is looking at other models that we can offer genetic testing through. And so I think that we can really learn from what's already been done and just kind of adapt our typical way that we provide genetic counseling, along with, of course, hopefully more resources like Kirsten mentioned.
Thanks very much, Lindsay. Liam, you touched on this a little bit before, but can you explain in a little bit more detail about the idea of polygenic risk scores and the idea that there's building evidence that the small changes to many genes might be really important in our cardiovascular risk, and more importantly, how does this look in the clinic, or when might this be something that people can expect as being part of standard care?
Yeah, it's a great question. I think Kirsten alluded to this distinction between monogenic and polygenic, which is a very important one. So one genic gene, the idea is there's one gene, one variant or mutation, typically a type of variant that totally disrupts the gene, so totally breaks the function of that gene, and that single variant is sufficient to lead to the clinical manifestations of the disease. So that would be like the classic monogenic disease, which is most of what genetics focused on for like the last 100 years. And so this would be things like familial hypercholesterolemia, certain types of hypertrophic cardiomyopathy that are these single gene disorders. Those individually are very, very rare, most of those conditions, although collectively they do affect many Canadians. Much more common, though, is polygenic conditions. So this would be things like heart disease in general, diabetes, high blood pressure. And so these are conditions that are caused not by one single gene, but by the action of many different genes and variants in different genes. Each of the variants probably has just a small effect on the risk, but the cumulative effect of having many, many variants that all increase risk of a certain condition can be a very substantial increase in risk, and sometimes even equivalent to the risk of a monogenic condition. It's a very new area in terms of how we can actually assess polygenic risk. And so one of the tools that's now being used primarily in research is something called a polygenic risk score, where we actually look at many different genetic variants throughout the genome. Some polygenic risk scores can be composed of maybe just a few genetic variants, maybe 10, maybe 20, but ones we're now using are actually composed of millions. So we actually look at, in some cases, 3 or 5 million genetic variants across the genome. We sum all of that information into a single value, which we call the polygenic risk score, and that is a number that reflects an individual's sort of the totality of their genetic risk for a certain condition. And what we know is that these polygenic risk scores are very powerful. So we can look at birth at a polygenic risk score, say, for heart disease, and there's a massive difference in terms of lifetime risk of developing heart disease in someone with a high versus a low polygenic risk score. We, in general, have not started using these as a clinical test because we're still really learning about what is the best way to use this information? What is the best way to communicate it to a patient? It's often not that straightforward to explain this concept. It takes time. It takes professionals like Lindsay or Kirsten, or they have to train people like Thomas and myself to actually be able to have these conversations with patients. And so we're really at the stage of trying to understand what is the best way to use this this new information. But it's undoubtedly a very powerful technology and something that we're going to be seeing a lot more of in the years to come.
Thanks, Liam. I think we're going to start with some of the questions coming from the audience. And Thomas, I'm hoping you can get us started with one of them here. It says, lots of good program information. Can you speak to the actual treatments and successes, timelines for therapy to succeed, and what's on the immediate horizon for these revolutionary treatments?
Sure. So I think I'm happy to answer that question. I think it's a fantastic question. And again, it varies depending on what type of condition that's, cardiovascular heritable condition you're talking about. What I would say first as a point of emphasis is that, being referred for a genetic assessment is very important because making a specific genetic diagnosis often leads to therapies that are currently available that are relatively simple and well tolerated, that have a very high chance of reducing a problem in future life. So a great example for that is the most common hereditary cardiovascular condition, which is familial hypercholesterolemia, which is when you're born with a liver that makes a very, very large amount of LDL cholesterol. And we know that initiating statins, even in late childhood and adolescence in families who have these conditions, dramatically reduces the risk of having a heart attack in early and midlife. So I would just emphasize that, for a lot of these conditions, we do currently have some excellent treatments that people wouldn't think of unless they potentially referred to a genetic specialist and discussed all the risks and benefits and what the diagnosis may be. And I'll move on to say sort of what does the future look like for this. So I think almost all of the individual cardiac genetic clinics within this larger cardiovascular genetics program are a part of clinical trials, which are studying novel therapies to treat specific disorders. So a few of our guests have asked about lipoprotein a. For example, right now in the Healthy Heart Prevention Clinic, there are studies looking at the new medications that could lower lipoprotein a, and we very much hope that in the next 3 or 4 years, we'll actually have medications on the market that are able to do that. There are other studies that we're involved in the cardiomyopathy space, the inherited arrhythmia space, looking at disease-specific, more precision therapies. These trials are ongoing, and we usually hope after running a trial, we'll have an answer within a few years. So I really think, when you compare what we've known 5 to 10 years ago about treatment, what it's going to look like 5 to 10 years from now, I think we'll see a lot of differences and a lot of improvements. And I think, we are still quite far away from genetic editing or editing the genome for common diseases. And I'd be hopeful that would happen in our lifetime. But probably the first conditions that we're going to start talking about gene editing for are the most serious, the most severe ones, where there are no good therapies out there that currently exist. And so we have a few trials in certain types of serious cardiomyopathies right now where we are looking at editing the genome as well. But all of these things, are a continual effort. And every year we kind of have a new option for a different type of cardiovascular genetic disease. So it really is a fantastic and excellent area of progress. And then, the last thing I'll say is that one of the benefits of an overarching cardiovascular genetic program across the province is that a lot of these new medications are extremely expensive, and they take time and resources to try to get patients on them, to get pharmacare to help cover them, to get private insurance to cover them. And that is a very resource intensive type of ask. And so, some of these programs don't just focus on diagnosis and genetic testing, but they also focus on trying to get patients on the best and emerging therapies for some of these conditions without other good options.
Thanks very much, Thomas. Kirsten, there's a couple of questions I want to just kind of put together. Craig Ivany has identified the need for some additional laboratory resources, and another attendee identified the fact that we also need imaging as part of this whole process. Can you maybe discuss a little bit how this process might all come together and comment a little bit on this?
Yes. Thanks, Erin, and thanks for the questions to the audience. So I think what I would say to that is So if I sort of focus first on the lab side, so wholeheartedly agree with Craig Tiffany on that comment. What we have been able to do so far is, and what we will hope to be able to enhance even further as we stand up a more standardized and provincial service, potentially as proposed in the future, is the ability to understand better how patients are currently accessing genetic testing, and what we might be looking for when we look to the future. So as part of the Cardiovascular Genetics Project through CSBC, we have brought together experts from across the province in various areas, and we formed both a steering committee and 2 focus groups. One focus group was specific to genetic testing in cardiovascular medicine. And through those discussions, we were able to identify what the current gaps are in genetic testing and what we currently have available for patients in the province. And an example in which we do need to build capacity within the laboratory setting is currently patients and families within BC who are at risk for inherited lipid disorders, specifically familial hypercholesterolemia, do not have access to publicly funded genetic testing or genetic counseling services. So that is an obvious gap for this group of diseases and this group of patients. And so we've been working with the Provincial Laboratory Medicine Service, as well as some of the genetics and genomics labs in BC on how we might fill that gap in the near term and gain access to genetic testing and counseling for this population where there has historically been none. So we are the last province in Canada to not publicly fund this testing for these patients. And so part of those discussions is building a business case for the testing, as well as how we might integrate that new test into sort of an end-to-end system that includes sort of a coordinated clinical service that can both be sort of the ordering providers as well as managing the results on the back end and ensuring that, again, the family is cared for as a unit. And so that's one example of where we're trying to build capacity on the laboratory setting. The other, like beyond that, of course, is, and this ties back into sort of the very beginning of this presentation is, as we learn more and more about the genetic basis for these conditions, we're realizing that the utility of genetic testing and genetic information is also expanding. And so we will be relying on genetic laboratory tests to get that good information now and in the future, and it will only become more expansive. And so currently, what are we accessing in terms of genetic testing? Most of it's happening out of the province and out of the country. Would there be opportunities, for example, to bring that testing and build the infrastructure within the province, repatriate it back to Canada? These are all questions that we're working on, and through CSBC, we've had the opportunity to again bring the experts together, lever their expertise and their experience, and come up with a plan for both filling the gaps in the near term and planning for the future, so that we can again ensure that patients and families have access to the genetic testing that's being recommended in the clinical guidelines that have been published. Sorry, I could go on and on because there's a lot to say there. And some of that touches on also what Lindsay's saying in terms of, okay, so you build out capacity for laboratory testing, but there has to be sort of a clinical management side to that. And so one important piece of that puzzle is genetic counseling, whether it's genetic counseling on the front and the back end, but ways in which we can increase access to not only the genetic information, but folks who can help patients and other care providers understand the information that's being fed back from the laboratories. And in terms of imaging, so one thing that we've been able to also do as part of this CSBC project is we have built within, so CSBC has a provincial cardiovascular genetics clinical registry called CBI Source, and we have built within that clinical registry a cardiovascular genetics registry that will be able to, if we are able to establish a sort of central triage system and start gathering data centrally on these patients and families in the province with these inherited cardiac conditions, we can start to answer questions of, where are these folks? where are they coming from, what are their needs, and with that good information that we can start collecting by bringing everything together under an umbrella service, we can start forecasting and projecting needs in other areas. So yes, one of the obvious needs is increased human health resources for genetic counseling, but access to diagnostics like imaging is another huge thing. And what are the needs of this population, and how are they currently accessing their diagnostics close to home? What are the barriers? And so again, bringing together these folks and this data can help us to advocate in areas of need. So perhaps that will aid us in having conversations with the government about access to diagnostics specifically for this population. And I think I'll sort of leave it there. So I think there's good things happening currently. We've made great headway, and yeah, we'll only sort of get brighter in the future, but lots of work to be done.
Thanks very much, Kirsten. We've got lots of questions still to come, and unfortunately, we're almost at time. So this will be our last question. Liam, we have a patient who's part of the Healthy Heart program who is interested in understanding when cascade screening might be available to help their son, and whether their son, since they are involved with the program, should consider getting involved.
Great. Okay. Well, thank you for the question, David. So, and we can talk about the details offline, which we obviously won't get into here, but in general terms, this actually gets back to something Kirsten was saying about, resources and what is available. So as she mentioned, BC is currently the only province for which clinical genetic testing for familial hypercholesterolemia is not available. So if you're a patient on this call and you have genetic high cholesterol, please write to your MLA and to the Minister of Health, Adrian Dix, and tell them that we need to have genetic testing for FH in British Columbia, and we should not be the only province that's left behind. Cascade testing, kind of similar, in an individual physician's office, most physicians do not have the resources or the tools or the time to actually perform cascade testing. So we do it in the Healthy Heart program as part of our research program. So we use research dollars that we get from grants to fund coordinators who help us to do cascade testing. But it's not something that's actually funded by the province as a reimbursed service. And there's a lot of barriers to cascade testing. So privacy legislation doesn't allow us to reach out directly to a family member. So if I'm looking after a patient who has, say, familial hypercholesterolemia, and I know that that patient's brother has a 50% chance of also having FH, I can't reach out to the brother myself. The most I can do is tell my patient, hey, your brother should really get tested. Can you tell him to go get his cholesterol tested? And, a lot of times that doesn't work because the patient may say, well, my brother's in Toronto and he doesn't have a doctor, or I hate my brother, I'm not going to tell him this. So there's a lot of barriers to actually making cascade testing happen. And so this is something that there's a lot of work to try to optimize the systems, to support the systems to do this, and also to address some of these challenges in terms of privacy, legality, and resources to do it. So that's just a quick blurb on what makes cascade testing difficult.
Thanks very much, Liam. I know there's lots of questions, and for those of you who have identified yourself, we will try to reach out after the session to follow up with them. But as we end, I very much want to thank Liam, Kirsten, Thomas, and Lindsay for your time and energy for this session. This was a great overview about the current opportunities and future plans for the use of evidence-based genetic testing in cardiology and how it can be part of the toolbox to help patients understand their cardiovascular risk. Before I end, I would like to highlight a few resources that are available from Genome BC. The first is a website that includes many resources to help expand your genomic knowledge. There's some courses, FAQs, and a number of videos that can help you understand some of these concepts, including some YouTube shorts around the power of cascade screening and genetic screening for hypertrophic cardiomyopathy. Both of these will appear in our social media channels next week as part of our Heart Month posting. Finally, I want to thank you all for joining us today. Your participation has been invaluable. Until next time, stay curious and keep the conversations going. Goodbye for now.